Oh, yeah. Oh, yeah. It is time to start. Good afternoon, top of the evening to everyone. My name is Dr. Randy Fink, and this is Fertility with Fink and Friends. I am Fink. You are friends. And as we are every Tuesday evening at this time, 4 o'clock in the mountains, 6 o'clock on the East Coast, five in the Central, and three on the West. We are live from Colorado Springs, where I am the clinical director of IVF services here at CNY Fertility, Colorado. It is great to be with you. Hello, Andre from Los Angeles. Good afternoon, Cecilia and Melissa. Haven't seen you for a while. Special hello to Miss Brandis Montez. Brandis Courtney is our wonderful nurse practitioner here. Hey to Tracy in Miami. Andre, you are number one on my Instagram feed over here. Thank you so much for being here. And Equestrian, thank you as well. We've got April. We've got Michelle Marks. Hello to Zenaida in Miami. Nice to see you. Heavenly Joy from Texas. The other Dixie Dean, it looks like. Hello. Happy Tuesday over here on the CNY Instagram side. Let's see who was number one. Ryan LS. Thank you for being here today. And Rosa SD. Let's see who we got there. Looks like Shani W. Hello to you. Jillian Sinatra. Thanks for being here. Mrs. Yozani. Emily Wynn. Hello to you. Cassidy Clark looks like. Ashley, Jenny, hello, Flawless, hello, Sharmila, and Janelle and CS Garza. Gosh, everybody is here today. And looks like Victoria, you are the first over there on the Facebook side. We've got Facebook and LinkedIn and YouTube here in the middle, and a couple of different Instagram feeds on both sides. CNY is here, and I am here. My name, again, Randy Fink, and it is great to be with you. Hey, our thoughts are going out this afternoon to all of our friends in Florida who are staring down the eye of a 44 Magnum barreling towards them across the Gulf of Mexico from the Yucatan. And, having lived in South Florida for 20 plus years, I know what that's like. And for those of you who have not had to deal with it, kind of as it's happening, you're sitting around and you're watching TV, and you watch this storm inch towards you, literally inch by inch, for days leading up to when it's going to hit you. And it just becomes, you sit there and you stare at the TV. It becomes mesmerizing. It's really hard to break out of it. And no matter what happens, and no matter how many times you've been through it, everybody's freaking out. There's probably no bread in the groceries. Milk is probably gone, just in case there becomes some national milk shortage as a result of a thunderstorm. People get very scared. It's very frightening, and in fact, when it comes back, it gets to be very triggering, because it's really truly a trauma to ride out that kind of storm. So our thoughts definitely go to all of our friends on the Central Coast. Now, you may know that CNY we have an office in Sarasota, Florida, and Sarasota seems to be right in the middle of the cone. If you're not familiar with, in South Florida, we would call it the cone of death. The cone is, sort of the predicted path with a 50th percentile kind of on either side. So it can go any place. The middle does not mean that's where it's going to go. But if you're in the middle of that cone, it sure makes you anxious. So lots of folks are vacating. They're getting out, just trying to get away from things. It's going to affect the entire state of Florida. Our thoughts are certainly with all of our friends at CNY Fertility Sarasota. Rest assured, your embryos are safe. Everything is safe. But CNY is also diverting folks who are scheduled to have procedures like retrievals and transfers, retrievals in particular, this week. In Sarasota are being sent to our other locations. So thoughts and prayers go out to Florida. Please take a moment to give thanks for all the things that we do have in our world, and hopes that this storm does not bring the kind of destruction that we saw only recently with the other named storm. So, that said, let's see if we can't answer some questions here. And what do we got there? Looks like Oh, thoughts on transferring this comes from Linda Wynn Trang. Thoughts from transferring a high level mosaic embryo. So, what is a mosaic embryo? When you do PGT testing on your embryo, means we grow the embryos up to the blastocyst stage, typically day 5 embryo, sometimes day 6, sometimes day 7. And they take a sample from some of the cells that are on the outside part of the embryo. That portion of the embryo is known as the trophectoderm. The trophectoderm is the part of the embryo that will become the placenta. So they take a few of those cells and they send them off because we're trying to determine which of the embryos are chromosomally normal. And when we have a chromosomally normal embryo, we know that embryo gives you your highest probability of success with IVF. And that is a 65% chance of pregnancy with that one embryo. A euploid embryo means an embryo that's chromosomally normal. Well, what's a mosaic then? A mosaic embryo is one that, so as you know, we have 2 sets of chromosomes. We've got 46 chromosomes or 23 pairs. Oh, I think I lost my picture there on Facebook. Let me see. There we go. Now we're back. Sorry about that. A mosaic embryo is where some portion of one set of those chromosomes is abnormal. That's what's called a mosaic. A mosaic embryo is not a throwaway embryo for a couple of reasons. Remember, again, with a PGT tested embryo, we're testing not from the baby itself. We're not taking a piece of the baby. Rather, we are taking a piece of the placenta. It is possible that you can have some portion of abnormal placenta with a completely normal baby. We also, as humans, have a DNA repair mechanism, and that repair mechanism may allow what appears to be a partially abnormal embryo to fix itself. So, a euploid embryo, we said, has a 65% probability of pregnancy. A mosaic embryo gives you about a 40 to 45% probability of pregnancy. So it's a little lower than a euploid, but it may be a little higher than if you had an untested embryo. So it's not a bad embryo. And the studies show us that if that embryo implants, if it sticks, then it has every bit the probability of becoming a normal baby, just like your euploid embryo, as does the euploid. So every bit as normal. There's a slightly higher risk for miscarriage with a mosaic embryo. But if that embryo sticks, it is every bit as likely to be normal. So how do I feel about transferring a mosaic embryo? I feel pretty doggone good about it, Linda. I think it's probably a good thing. Now, the things that worry me when we talk about transferring mosaic embryos are embryos that are trisomy 13, embryos that are trisomy 18, or trisomy 21. So 13, 18, 21, those are all embryos that can actually be born with an abnormality. And in general, what the data shows us is that there's no higher risk for having any kind of abnormality if that embryo otherwise sticks. So I would keep away from the trisomy 13, trisomy 18, trisomy 21s. But otherwise, a mosaic embryo is fine to transfer. May even be better than your untested embryo. Desi Banks says, can you discuss what to expect during an initial consultation with a fertility specialist? So when you contact us at CNY, you will have it's a telephone, a virtual consultation. So it's telemedicine visit where we go over all of your history. If you've had treatment before, we'll want to know about that. If you've had testing done, we'll want to be able to see that. If we have any history of a treatment, then we kind of want to know, well, what worked for you before. And even if you haven't, we'll talk about what the evaluation is, what the testing is that we'll want to do for you in terms of hormone levels and imaging. And then we'll develop a plan for what's going to be the best choice for you for being able to get pregnant. Now, if you go to a fertility practice and see a doctor in the office like you would in a normal, regular doctor's office visits, oftentimes you will have an ultrasound performed that day. Not always, but sometimes, and sometimes some portion of a physical examination. Although in reality, those things really don't significantly change what it is that we're going to do, what our plans would be. So that's why we're really able to do it through telemedicine. Let's see, we got a bunch of folks over here on the Facebook side that joined. Does Victoria ask, does having a transabdominal cerclage make a transfer more difficult? I just got mine placed and will transfer at the end of December to January. So a cerclage is a type of stitch. It's a stitch that's placed in the cervix to help hold the cervix closed. That is a surgical procedure that we do for cervical incompetence, for an incompetent cervix, which means the cervix, which normally holds the baby on the inside, is for whatever reason not strong enough to be able to do that. And so therefore it needs some support. And so we put a stitch in it, and that keeps the cervix closed. Most of those stitches are done through the vagina and actually into the portion of the cervix that we would actually be able to look at, that you'd actually be able to see on the inside. An abdominal cerclage is one that's done literally not through the vagina, but the stitch is placed higher up and requires some type of open surgery. Sometimes it can be done laparoscopically, but a more significant surgery. Now, the bigger concern I would have with your abdominal cerclage is there any cervix in the vagina anyway? Because sometimes in that scenario, the reason they're doing an abdominal cerclage is because there's not enough cervix inside the vagina. And if there's not enough cervix, it can make doing a transfer difficult because it makes it very hard for us to see where the opening lies. So my recommendation to you would be maybe we do a mock transfer. Maybe we take a good look and make sure that we're going to be able to get there easily. So it's the safest, most direct route for your embryo. That would be my recommendation. Let's see what else we got here. Jessica says, no questions. Currently 21 weeks with my CNY miracle boy. That is awesome. Praying for all of you in Florida and all your embryos safely. Can't imagine the stress. Yes, indeed. Jessica, very kind. Thank you very, very much. Hello to Stardust. Stardust Redbow says transferring a 3-day 3 embryo, does transferring 3-day 3 embryos reduce their chances of implantation? No. Well, it depends, actually. It depends on how old you are. So if you're in your 40s, then placing 3 embryos is completely within the guidelines. And we would do it. If you were, let's say, 30 years old, then transferring 3 embryos poses a dramatic and unacceptable risk for multiple gestations, and we would not do it. So no, it doesn't decrease the risk for implantation. Rather, in the age cohort in our 40s, transferring multiple embryos can improve the chances of pregnancy. Now, that same thing may not hold true at younger ages. So please make sure that you talk to us about what that risk actually is. But in your case, Stardust, nope, you're good to go. Hello, Mrs. Keybell. Looking forward to seeing you next week as well. Samantha Baxter says, what's the process of getting a frozen embryo to PGT testing? I did not get them done before freezing, but I'd like to do that now. So it depends, the risk that entails on your embryo depends on what kind of embryos you have. So if you've got day 5 embryos, if you've got blastocysts, we can definitely thaw them, biopsy them, and refreeze them. And then when that PGT comes back and we know which ones are normal, we can thaw that embryo again and then transfer it to you. The problem is when we're doing that, we're theoretically putting those embryos at some risk because each embryo has a finite little tank of gas. That's a good way to think of it. It has a finite energy supply, and every time we do something to it, we are potentially using up some of that energy. So, what I mean by that is that think of it as a tank of gas. It's going to cost a little bit of gas to thaw that embryo. It's going to cost a little bit of gas to it when we do a biopsy. And then we're going to have to go through the process of refreezing it again. That's going to cost it more gas. Then we're going to thaw it again, and that's going to cost even more gas. Eventually, at some point, it may run out of gas. It's a finite tank of gas, and we don't know how much it may affect a different embryo. Each different embryo may be affected differently. So there is theoretically some risk for doing that if what you have is blasts. Now, if you've got a bunch of day 3 embryos, it actually costs less energy on those embryos to thaw the day 3 embryo, let it grow to blast. Some of them won't make it to blast. Some of them are going to die off because they're not normal embryos. But some of them will make it to blast, and then you biopsy and you freeze them. That is much less costly energy-wise to the embryo than would be taking a blast, freezing it, thawing it, biopsying it, refreezing it, and then thawing it again. So does that make sense? The process is you would just send a portal message into wherever your embryos are, that embryology team, and say, hey, I would like to thaw and biopsy my embryos for PGT. There's different consent forms that they'll have you sign. There is a cost that's associated with doing that. I don't know exactly what that cost is, but so that's kind of the process there. Let's see. Raina Rickman says, I just transferred a day 6 PGT normal. My progesterone was at 13 for transfer. When can I test at home? So usually that pregnancy test is about is 10 days later is when we'll do the beta, but you can, probably from a day or two before that, you can do a urine pregnancy test if you want, but don't let the urine pregnancy test be the end all for you because sometimes the embryo may take a little bit of time before it implants, and your urine pregnancy test may be negative. It also depends on what type of urine pregnancy test you're using and how sensitive it is. Best option is to wait for the beta. But if you can't hold out, certainly by day 9 or 10 after, by 8 or 9 rather, after transfer, you can do it. We'll be doing the beta typically about day 10. Let's see who we got over here on the CNY side. Thank you all for your patience. Sharmila asks, after an egg retrieval, how much time is needed to wait for an FET? After PGT, can we go for FET the next month? Yes, you absolutely can, Sharmila. So when you get your results back, now some people opt to go directly into a transfer cycle in the anticipation that they're going to get the PGT embryo that they want and that it will come back before it's otherwise time to transfer. There's always some slight risk that doesn't happen, but you can go into transfer the very next month. But if you're going to wait for the PGT to come back the very next month is also fine for transfer. Hi to Damaris. Janelle Mosley, good afternoon. CS Garza says, what is the ideal progesterone level for a transfer? Well, so it depends on what type of transfer you're doing. In a medicated cycle at CNY, we look for your progesterone level to be a 20. If it's not a 20, we will recommend that you increase the amount of the progesterone in oil you're getting. If you are doing a natural or a modified natural embryo transfer cycle, then we look for that progesterone level to be at a 10. Now, realize this. In nature, when you have ovulated, your progesterone level is about a 2.5 is the minimum. So we're talking about building in a very large and a very wide safety zone there with progesterone levels. But you can, so here at CNY, and every place may be a little bit different in terms of what their norms are. But for natural cycle, we look for a progesterone of 10. For a medicated cycle, we look for it to be 20. If people also ask, what about my estrogen level? Estrogen, it doesn't matter. So if you were with us last week, we talked a little bit about that we test it just because people expect for it to be tested, but the number doesn't make a difference as long as the uterine lining was thick enough. That's really the only thing that we need that estrogen for. Another common question people say, well, what about, why don't you measure my uterine lining at the time of embryo transfer? You told me it has to be, at least 7 millimeters when I start my progesterone. Don't you want to know what it is when I'm doing the transfer? Or people will say, what is the lining? What's the number? I got to know the number. You don't, because once you start using the progesterone, that lining of the uterus starts to compact. It gets tighter, it gets thicker, and it gets kind of more ready to be able to hold on to the pregnancy. But so the number of what the endometrium measures at the time of transfer is not really at all important. It's more important about what it is at the time of progesterone start. Ashley VZ says, I had a chemical pregnancy with my first embryo transfer. The second FET was negative. Both were modified natural. Should I do another modified if it worked the first time, even though it was chemical? Should you? Well, they say that the modified natural and the medicated cycle are at the very least equivalent. So there should not be a substantial difference in outcomes, although there are some studies that show us that a modified natural is actually a little better. We know that it creates fewer some certain types of pregnancy complications later on. It probably has a little lower miscarriage risk. And in my personal opinion, I think it's much easier on your body to do a modified natural. The biochemical pregnancy means that you had a pregnancy that implanted. We got a positive pregnancy test with a number, but the pregnancy did not continue to grow. And so it resulted really only in a number showing us the pregnancy was positive, not so much being able to do an ultrasound, see a pregnancy inside the uterus. That's what we would call a clinical pregnancy. That biochemical pregnancy, Ashley, is 1/2 step in the right direction. That means that the brain was talking and the uterus was listening. The embryo was able to implant. It just didn't continue to grow. In most cases, particularly with the first biochemical pregnancy, we say that that's an embryo issue, that's not so much a mom issue as much as it is the embryo itself. So I agree with you. That tells me that modified natural worked for you. So therefore, I would say, I think you're fine to stay with it. Now, if you changed your mind and you said, you know what, it just makes me nervous, I really want to do a medicated cycle. In the medicated cycle, we are taking all of the variables out of it because we're giving you all that hormone. We're taking away the body's ability to do it itself. And, we're giving it all to you. So if you're at all anxious about it, it's not a problem to switch over to a medicated cycle. But in your case, I think that you're fine to stay with a modified natural. Let's see here. Hello. Looks like Himna Vega or Jimna, if I'm saying it right. Hello from Colorado, and hello from Colorado as you. Mrs. Lozani is in Rochester. Cassidy Clark says, for a BMI at Colorado, I believe the requirement is 50. But what if our BMI is 50.7? I don't think we would turn you away. Jess Indris is with us. Rosa SD says, can a day 7 3BB, that's a grade blastocyst, test euploid? Yes, it absolutely can. Can a day 7 blast have less of a chance of euploidy? Well, day 7 blasts don't perform as well as day 5 or day 6 blastocysts. So if it takes 7 days for that embryo to become a blastocyst, we would say statistically it has a lower probability of getting you a pregnancy. However, we see every single day people who have lower graded embryos or embryos that someone else would have said, ooh, that's not going to be a good embryo, turn out to be their euploid embryos. So if that embryo tests euploid, if it tests chromosomally normal, then Rosa, it has much higher chance of getting you pregnant than any day 5 or day 6 embryo that didn't test normal. So that's kind of how I look at that. Emily R. Wynn says, what do you want progesterone, estrone to be at beta with an HCG wash before FET and daily HCG boosters? Okay, so again, estrogen, we don't care. Estrogen, it doesn't matter to me what your estrogen level is as long as your lining was thick enough. When you do an HCG wash is where we take the pregnancy hormone and we place it inside the uterus. We're literally washing that uterine lining with the pregnancy hormone. What does it do? It helps to turn on some of the receptors. It helps to turn up the volume on the receptor type apparatus inside that cause people to be able to get an embryo to implant. So that's the purpose of the HCG wash. It does not get into your system. So an HCG wash should not cause any beta HCG or pregnancy test to be positive. However, an HCG booster will cause your pregnancy test to be positive. Usually that number is typically between a 15 and a 20. So if you're going to be doing an HCG booster, which is what I recommend if you're doing a natural or a modified natural cycle, HCG is metabolized in the body as more progesterone. We talked about progesterone is what your body wants. It's thirsty for progesterone when it comes time to get that embryo to implant. The HCG booster is a good idea in a natural cycle. In a medicated cycle, gosh, we're giving you so much progesterone already in the form of the progesterone in oil. I don't feel like the HCG booster is really very helpful. But in any event, if you are injecting a little HCG into the fat cells here, and then we go to do a blood test for you, and we're testing for HCG, guess what's going to be positive, right? We're putting it in your body, it's going to be there. So that first pregnancy test is going to be positive. And I always warn people about that so that that doesn't become a major stressor. Expect the first one will be positive. The way that we're going to tell if you're really pregnant is that 48 hours later, we're going to repeat a beta HCG. And if you've got a pregnancy inside that's making beta HCG, we're going to see that number going up. Typically, it doubles in 48 hours. So that's how we look at it. It's not the first blood test that you do that's going to show you that you're pregnant. It's going to be the second one. Typically, a positive as a result of an HCG wash is going to be usually a beta between 15 and 20. Let's see, go back over here. Siciliana Melissa says, thoughts about, I'm currently 21 weeks. I didn't realize, that is awesome. With our miracle boy, thanks to CNY. Thoughts about induction at 39 weeks due to advanced maternal age and IVF status. So what you're talking about is, do I wait to go into labor on my own, or do I get my pregnancy induced so that I can go ahead and have my baby? So when I practiced obstetrics, I feel very strongly that induction is not a bad thing at all if and only if the cervix is ready to open and you're 39 weeks. So the data shows us we don't electively want to deliver you before 39 weeks because we want to make sure that the baby's lungs are mature on the inside before the baby comes out. So assuming you're 39 weeks, well, you're going to get your cervix checked. What are they checking for? So we place our fingers in the vagina and we're feeling around on the inside there. The cervix, so if you reach inside, you touch, your cervix feels like the tip of your nose. But when you're pregnant and we go to check your cervix, I'm placing fingers inside there. The cervix starts to do a couple of different things. Let's say this is the cervix. The cervix starts to thin out. That's what's called effacement. And we measure that. We can usually either say, well, the cervix is 2 centimeters long, or we may say the cervix is 50% effaced. That means it's going from its full length to half of its length. Then it starts to dilate. It starts to open up, right? And so fingers go in. That's what I was starting to say here. That's 3 centimeters when I can get my 2 fingers there. That's 3 centimeters. And then 4, and then 5, and then 6. And when you've done that a million times, you know you can take that measurement just based on how it feels. And then the third thing we look at is called the station. The station is, where is the presenting part, like the baby's head? Where are we feeling the baby's head? How high up is the baby's head in the pelvis? Or is it engaged? Is it starting to come down into the bony pelvis? So that ultimately equates to a question of, is your cervix favorable? And there's actually a score that we can give you. That's called a Bishop's score. And a Bishop's score that is above, if I remember, a 7 tells me, oh, your cervix is damn favorable. Meaning to say, if you've got a really good, favorable cervix and you're 39 weeks, then the data shows us there's really no added benefit to staying pregnant any longer. That inducing you does not increase your risk for C-section. It does not increase the risk of the baby having to spend some time in the NICU. Lung maturity is expected to be there. So if it's safe, then I'd say no reason not to. Now, sometimes we can induce people naturally. Have you ever heard of what's called stripping the cervix? Stripping the cervix, or stripping the membranes, is where basically we use our fingers to kind of loosen up around the cervix, because the bag of water, the amniotic fluid, is sort of sitting right on the back of the cervix, like so. And if we can separate that out a little bit, then that can cause the cascade of hormones that may begin the process of labor, especially if we strip your membranes and you go home and you have sex, because semen has a chemical in it that's called prostaglandin. Prostaglandin is what thins out the cervix and makes it more ripened. So my feeling is 39 weeks, favorable cervix, go ahead, absolutely. Now, if the cervix is long and closed and there is nothing going on and there's no other obstetric reason, as long as the fetal testing is reassuring, that is to say, you've got enough amniotic fluid, baby looks happy on the inside, usually then we will hold off. That most of the time we will. Now, in some places, they will say that if you are of advanced maternal age, that is an indication for medical induction at 39 weeks. So it really kind of depends all on your hospital situation and on your obstetrician and how they feel about it. Because I don't feel like doing an induction of labor is a good thing if it means, wow, we're really just kind of trying to increase your C-section risk. Get a vaginal delivery if you can have a vaginal delivery, unless you don't want one. If you don't want one, you can ask for a C-section. That's fine too. But favorable cervix is really kind of what we're looking for there, Melissa. Let's see. Mel Bell says, is there any alternative to lipids if you can't find them somewhere to do them, like extra fish oil, MCT oil? Nowhere will do them. So Mel Bell is talking about getting the intralipid infusion, and that's an IV therapy. So if you come here to our office, we will do the lipids here because we do infusions here. However, many places, it's hard outside in the community to find a place that will do infusions for you. And so sometimes people have a friend who's a nurse who will hang it for you. Believe it or not, some people go to veterinary clinics to have it done. I'm not sure how comfortable I personally would be with that. I went to get my lipids and I was sitting next to this German Shepherd, and I swear this was the craziest dog. I read a book about that. Lipids and Labradors. Yeah, some people will, wherever you can get it done. Now, in many cases, our CNY facility will do your lipid infusion on the day of transfer. Ideally, we want to have it done in the day or two before, just like when you're doing an HCG wash. So it might be worth coming into town a day early to get it done. But if not, just ask if you can get your lipids scheduled at the time of your transfer. Hello to Ruzik Blue from Las Vegas. Oh, and thank you for wishing me a happy birthday. I forgot all about saying that. I should have said that at the top of the show. Thank you so much to all of those of you who sent me birthday wishes. It was October the 4th. Which was last Friday, and I had a wonderful day here. It's kind of the one day at work where all your colleagues act as though they like you, and so it was really it was a very pleasant. I had a very good day. I had a really nice birthday weekend, but more importantly, I got really some. A lot of really heartfelt and sincere and lovely birthday wishes from all my friends out there, and I really truly do appreciate it. And also, um, I'm so excited because I turned 21 and I had my first sip of wine, um, and it was dang, it was quite the experience. And I'm a little prematurely gray for 21, but looking forward to my 20s now, and we'll see how that goes. Don't you roll your eyes at me either, okay? Thank you. Noodles for life. If I am taking prednisone, metformin, and LDM long term for egg retrieval or transfer, does it have negative side effects on the body? I do not recommend that you take prednisone long term. So if you're taking a break between, let's say, a retrieval and a transfer, and you're on these other things, metformin is kind of considered a life hack. So in the anti-aging community, we put people on metformin. It's considered pretty good for you. Metformin can diminish your B6 vitamins, and so it's probably good to be taking a multivitamin that has some form of B complex if you're on metformin. But metformin is good. Low-dose naltrexone, same thing. People are on low-dose naltrexone for years and years in the anti-aging community, and they say that when you're on it for long term, you never get sick. You'll never get a cold. You'll never get the flu. It has a very strong effect on kind of boosting the immune system there. So I think those are fine, but prednisone, I would not want you to stay on long term. Prednisone can have some very detrimental effects on you over the long haul. Sometimes what happens is that people get on it, they forget to get off, and it just becomes this thing that they've been on for month after month. Do taper your progesterone, your prednisone off. I don't want you to stay on that long term. Let's see here. Sabrina Hussein on Facebook says, if my estrogen is high at baseline for FET, should I still proceed? Yes. Again, I'm not so worried about your estrogen level as long as your lining is thick enough. Danielle King says, for a couple with MFI, male factor infertility, okay, and a low normal AMH, we were told to go with IVF. So we're saving money. But would you guys be willing to do some medicated cycles or medication for the male dealing with low motility? Well, there are not specific medications that we can use for sperm motility. Now, if the motility is at least sufficient that there is some forward motion and the count is high enough, you can always do an insemination, an IUI, because that's going to be putting sperm in the right spot to maximize the odds of sperm meeting egg. And in so doing, we are separating out the sperm that are the best and the strongest swimmers. But as far as taking a medication that will simply improve sperm swimming, unfortunately, no such medication exists right now. Can you share your thoughts with a polyp during a frozen embryo transfer? So we don't want a polyp to be there. A polyp is a finger-like growth of tissue that lives inside the uterine cavity. It sticks up like a tree trunk or it hangs down like an icicle. A polyp is a representation of an abnormality in the lining. And so we want those, not only is there a direct effect of the polyp, like it can sit in there and act like a little baseball bat and knock your embryo out of whack, but it's taking up valuable real estate is the way I like to look at it, that ultimately would be used by your embryo for implantation. So if there's a polyp there, it would be a standard of care to take it out. If we knew that there was a polyp there and we said, never mind, just go ahead and do your embryo transfer, I don't think that would be a very good idea. That sounds sort of not like a good plan to me. Lauren Dolahite says, waiting on my second consultation appointment with the doctor so that I can start IVF. Not sure why you need a second, but eager to get started. And Lauren, we are eager to have you. That's fantastic. Amanda Grace says, I just had my positive second beta with my fresh transfer. And we transferred a day 5, 3 AA and a 4 AA. Congratulations. That is awesome. It was your fourth transfer, but your first fresh. You did PGTA last time, and your first was a chemical. Your second was a blighted ovum, and the third was nothing. So you go, girl. That is fantastic. Glad to hear it. Subrina Hussein said, what's the difference between a modified and a medicated FET? Basically in a natural cycle or a modified natural, we are letting your body produce the hormones. You're taking the front seat in terms of making the hormones that we need for you to be able to get pregnant. So often a modified natural will give you ovulation induction. We'll give you some letrozole to make sure that you're going to produce an egg. We will trigger that ovulation, or we can trigger the ovulation when that follicle is mature. So that causes you to make your own estrogen. When you release the egg, you make your own progesterone. And that's how that works. That's a modified natural. It's an ovulatory cycle. We're trying to get you to ovulate so that you will make your own hormones. Whereas in a medicated cycle, we're giving you all the meds. We're giving you the estrogen. We're giving you the progesterone so that there are no variables involved. There's no, well, maybe it's going to work, maybe it's not, because we are stopping your body's ability to do it, and we are just paving the whole road with our hormones instead of letting your body take the lead on it. So that's what the difference is there. Let's see. Max at Play is saying hi from Tampa. Max, I wonder if you're still in town or if you're gonna be getting out of Dodge. Sexy as candy. I'm sure that's what that says. Hello from Indiana. Hello to you, my friend. Hey to Liz. Can Oralissa be unsuccessful? This is from Rosa for suppression of advanced endometriosis. 60 days is really all you need of suppression. Suppression in the data has shown us that it does the trick. So does somebody's body not obey the rules? Maybe so, but in general, that's considered a standard of care. So Rosa, you can feel pretty confident there. Ryan says, my wife is 34, otherwise healthy. Our first IVF cycle yielded 1 euploid embryo. For silent endometriosis, why versus why not go for excision surgery now versus later? Okay, so with endometriosis, and you have a 3.5 centimeter endometrioma, and you said silent endometriosis. To me, that's not silent endometriosis. To me, that's endometriosis. Silent endometriosis is when you have no idea that you have it. We don't see it anywhere. You don't feel it. You never have any symptoms. We do a receptiva test and it comes back positive, or you have a laparoscopy and lo and behold, there's endometriosis, but we had no idea beforehand that you had it. Well, so now you've got a big old endometrioma cyst in the ovary, endometriosis collection in the ovary there. And so I'd say, well, it's not so silent anymore, right? So we know it's there. When you go to take an endometrioma out of the ovary, it will diminish your ovarian reserve. Your AMH level will go down. And as that AMH goes down, that means that there will be a lower response to medication if you are going to do IVF. Furthermore, we always recommend that you get your eggs, you do your IVF as early as you can, because every day that goes by, you're one day older, right? We don't get younger. Well, except for me, of course. Yeah. You people, we don't get younger as the days go by, right? We only get older. And as we get older, the egg quality starts to diminish. So, the earlier you get your eggs, the better off you are, the more likely you are to be able to make chromosomally normal euploid embryos. So the sooner you can do it, the better off you are. I'd rather you do that and then worry about fixing up the endometriosis later on. Get all your eggs, bank up your embryos, and then worry about treating the endometriosis, both for suppression for transfer and for, if it just doesn't feel good, if you're having symptoms from it, do that after the fact, because the sooner you get your eggs, the better off you're going to be. And if we start digging in the ovary, it's going to have a negative effect on the ovarian reserve. Hopefully that's helpful there, Ryan. We'd be happy to talk to you guys about that as well. Does low blood pressure impact an FET in pregnancy? Because mine is 80/47. No, because that's where you live. That's your normal kind of blood pressure. Now, high blood pressure can impact. So we have people who come in for an embryo transfer. We take their blood pressure and it's 220/110. If that's the scenario, I'd say don't transfer your embryo, because that may mean that your uterus is being starved for blood supply because the blood pressure is so high. The blood vessels are so tight. Low blood pressure is fine, Sharmella. So I think you're okay in that regard. Hello to Lainey Kaufman. Blaxican Beauty says, I just had my SIS done at Sarasota and they found another polyp. Ay, ay, ay. I don't know why I keep getting these. Is there anything I can do to help prevent them from recurring? Well, so I think part of it depends on how long has it been. So my first question is, well, was the first one removed correctly? So I know that if I did your polypectomy, it was removed correctly. But as you're taking a polyp out, you have to go all the way down to the base of the polyp, because what's happening there is that the little cells that make up the endometrium, they all have hormone receptors. They are all listening for the signal from the hormone. And if they're hearing too much signal, which means to say there's too many little TV antennas on top of those cells, they're hearing too much signal, it's going to cause that polyp to grow. So you want to make sure that you're removing the entire polyp all the way down to its base so that there's no little piece of polyp that's left over to regrow. Now, that said, some people just are polyp makers. What can you do about that? There's some thoughts that being on some extra progesterone may help with that. Certainly, a progesterone secreting IUD is a good tool to help prevent polyps from growing back. But sounds like you just you want to get that done, get yourself pregnant, and then you don't have to worry about the polyps too much anymore. That sounds like an easy plan, but sometimes obviously easier said than done. Let's see here. This is Janine Noto. Janine Noto had our transfer last Tuesday after oral suppression. The urine test Wednesday was negative at 6 days post-transfer. I would not expect it to be positive at 6 days post-transfer. Is this because our embryo was a day 7 PGTA normal? No. So basically, whether you have a day 5, whether you have a day 6, whether you have a day 7, that just means it's hard to think about it but think about it this way. It means it took 7 days for that embryo to think it was a day 5 embryo. So it doesn't change the timing of your embryo transfer. And the fact that that was a PGTA normal embryo means it gives you a 65% chance of being pregnant. Day 6 post-transfer, I would not expect a urine pregnancy test to be positive, because that number is likely still going to be too low to trigger a urine pregnancy test. Laney Kaufman says, with a low AMH of 1.2 at age 35, that's not too bad. Would you recommend low dose or normal protocol IVF? No known issues outside of recurrent pregnancy loss after a tubal ligation reversal. So at 35, I would recommend, not knowing anything else about you, Laney, I would go with a standard dose IVF. Standard dose for you would be about 300 units of HCG, LH, either 20 or 30 units of HCG. If you're using Menopur, the dosing might be a little different there, but I would not use a mini dose. Now, if you're, to be honest with you, even if your AMH was 0.4, then I'd say, yep, that's a diminished ovarian reserve. I would still opt for my first cycle being at the age appropriate dose. Because what we know about the mini dose is that when you compare it to a very high dose therapy, we get the same kind of results. But that is not the same to be said for those who are using an age appropriate dose. Now, what do I mean by that? In the olden days, we would say if you came to us with a diminished ovarian reserve, let's say an AMH of less than 1, the classic wisdom was, we're going to give you as much medication as we can pour on your ovaries in order to try to get you to respond. People would be using these very, very high doses of therapy, and there's still a lot of practices that's what they do. That doesn't usually work because the ovaries they don't know what they're supposed to do with all that stimulation. So what they learned really from the European experience, which is where in Europe, the governments pay for IVF. They tell you what the dose you're going to be on. They don't care if you get 2 eggs or 20 eggs. Everybody's going to be on a little dose. What they found is that on these low doses, people did really just as well as they did on the very high doses. But remember, with the very high doses, we're going to get some diminishing returns. So there is a middle ground there, and that's the age appropriate dose for you, Laney. And so that's what I would do. You would fall into the standard dose bundle if you're using the bundles. I would use 300 and either 20 or 30 of HCG, 300 of FSH, unless you're doing Menopur, and then it's a little different dosing. Lillian Gomez, nice to meet you. I hope you have a nice afternoon. Well, thank you. What a very nice thing of you to say. I appreciate that. Let's see here. We got something else I saw. I just finished the stimulation treatment and the eggs have already been extracted and embryo was obtained. Do you recommend another stim cycle? Well, so part of that depends on how old you are. How likely it is that you're going to get pregnant from a single embryo. Remember that IVF is a numbers game. Really and truly it is. It's about making enough eggs to get enough embryos so that you can make normal embryos, because it's the normal embryos that stick. If you have just one embryo, in all probability, we will feel a lot better if you have more than one embryo. So given that, not knowing anything else about you, I'd say, well, I'd probably feel more comfortable if you had more than one embryo. So another cycle might be the best choice. Hey, it's about 6 minutes till the top of the hour. I forgot to say something 25 minutes ago, but this is Fertility with Fink and Friends. I am Fink and you are friends, and we are live as we are every Tuesday evening from CNY Fertility in Colorado Springs. Ask your questions, please. Love to talk to you, and come back every week because this is a great group of people, very supportive, wonderful people, and we're only too happy to be able to help you here. Over on the Facebook side, a couple of happy belated birthdays. Thank you, Sabrina. I appreciate that. Nicole says, have you worked with patients with isolated azoteratospermia? We had our urologist say it's no big deal, but then our RE said it's the reason that we can't conceive. Oh, teratozoospermia. Well, okay, so teratospermia means that there is abnormal morphology. Morphology is when you look at a sperm and it has a normal head, it has a normal neck, it has a normal tail. People look in the microscope and they can tell what is normal and what is not. Um, so, teratospermia or abnormal morphology is not said to be a cause of infertility, but rather it is associated with couples who have a difficult time conceiving. So, not a cause, but an association. It is something that we can easily overcome by using IVF. So, yes, that is something we do. Now, just to make sure that we're talking about the same thing there. If it's azospermia means no sperm, and that's a much bigger problem because we have to have sperm to fertilize an egg. And usually the urologist has to do a procedure on the testicle in order to be able to try to extract sperm. There's also some other terminology that means extremely low morphology. But again, with IVF, we often are able to overcome that in a variety of different ways. So yes, ICSI is one of the things because we take the sperm and place it right into the egg, and that creates your embryos. That's one way to do it. And there's also a device that's called Zymot, Z-Y-M-O-T. Zymot is a sperm selection device that lets us select sperm from a stronger group of sperm and a group of sperm that, in theory, may be a little bit more normal. At CNY, Zymot, and they have a nice website if you want to read about it, ZYMOT. If you want to read about it, do that. Zymot at CNY is a $200 add-on, and I think it's well worth it, particularly with known issues with teratospermia and also for those who have otherwise unexplained infertility, because there's some degree of those folks who have DNA fragmentation. They have issues with the genetic material in the sperm that you can't tell from looking at them, and this just helps us to select those out. Let's see. Beverly Salamanca says, if I'm ovulating, why was the specialist pushing donor egg only? Me and my husband now looking into your practice. She wanted to do an invasive procedure I've never heard of, right across the right off. Never heard of, right off back. Okay, so Beverly, my guess is that has something to do with age. Donor egg, many practices will say, well, if you're over 42 years old, you can't use your own egg because it means that you have such a low probability of getting pregnant and it's going to mess up our numbers. So we don't want to show that we're treating you. So therefore you should be using a donor egg. We're not gonna do IVF with your egg. That may be the reason why. So ovulating just means that you're producing the egg. But remember, those eggs have been there since you were in utero. And so if you're in your 40s, those eggs have been there for a long time and have a long time for the DNA to become unstable. And given that, that means that you are less likely to produce a normal egg, which means less likely to make a normal embryo, which means you won't get an embryo to implant. Now, at CNY, absolutely positively, we allow you to use your own egg, because who am I to say that you're not going to get a normal egg? You absolutely might. And we will try like hell to be able to get you there. But CNY reports its data differently than many other practices. We don't care about the pregnancy rate that we are reporting. We are not cherry picking our IVF patients so that we can report an artificially high success rate. And by that, if you look at the numbers, you'll say, gosh, their success rate isn't very good. Well, that's because we're looking at everybody that we treat across the board. So if you look at a 21-year-old, she has an extraordinarily high probability of producing a normal egg and getting pregnant. If you look at a 42-year-old, she has a much lower chance. But we include all those numbers in the same big basket. And that's why the numbers really don't count. And that's probably the reason, Beverly, that practice was trying to talk you out of IVF, unless you wanted to use a donor egg that was going to give a higher probability of pregnancy, because they want to be able to say, our pregnancy rate is 90% or something, that's astronomically high and artificially high. That's kind of the reality of that. Can you do an IVF on hormone replacement therapy? And that comes from Jessica. Well, if you're on hormone replacement therapy, probably it says to me that you are in the menopausal years and you may not have eggs that will be able to stimulate from your ovaries. So I'd want to know a little more about that to see if there is, is there going to be a chance for success in that scenario? Jennifer Perez says, what are the chances of having a normal embryo with really low ovarian reserve? And I'm talking around 0.03. So at 0.03, that number is considered essentially negative. So oftentimes we'll see women in the menopause who may not have any eggs remaining at 0.03. Now, all that number the AMH tells us is about your expected response to IVF medication. It doesn't say anything about your ability to get pregnant on your own or really what that egg quality might be. So, it sounds like it's a much larger story there, Jennifer. And so we'll keep our fingers crossed for you and hope we can help, because that may be something that we can talk about. So it looks like, gosh, we are out of time here, folks. May I again ask you to keep Florida in your prayers as we approach this next few days when the storm is going to hit on the West Coast. All our thoughts are with our friends and colleagues in Sarasota. And as I always say, the world is not a kind enough place. Every step forward with kindness. Please do something for a stranger. That's just a random act of kindness. Would you? If you don't mind, just do it. It'll make you feel better, and I think it'll make the world a better place. Smile at a stranger, be nice to a child, stop and pet somebody's dog. Every step forward with love and with hope, knowing that tomorrow is a new day, and whatever happened today and yesterday, just a figment of our memory. The wind blows, the sun comes up. Tomorrow brings us new hope. This fertility business is not the story of your life. It is but a chapter. And what are we doing? We are here to rewrite it together. So until next Tuesday, I'm Dr. Randy Fink from CNY Fertility in Colorado Springs, saying good night.